Hey, nice to have you with us on this Wednesday. Being a Wednesday, of course, we look at things medical, and we're joined, as usual, by our resident GP, Dr. Vicky Skitter. Hello, Dr. Vicky.
Hello, Jeremy.
Nice to see you again.
Nice to see you too.
And you alerted us via email that this month is a very special month.
Yes, it is Angina Month.
Oh, I didn't read it properly. Angina Month.
Yes, Angina Month.
Right. Now, tell me about it.
Okay, so what is angina? Angina is a type of chest pain that occurs when there's a reduced blood flow to the heart muscle. This is usually a symptom of coronary artery disease. The coronary arteries are those arteries that supply the heart muscle with blood and oxygen, obviously. So if there's reduced blood flow or oxygen, a condition occurs that we call ischemia, and that's reduced oxygen or deprivation of oxygen, and that's when angina occurs. So it's usually a vice type grip pain of the chest, heaviness or pressure or tightness of the chest. Females, because we're special, sometimes get atypical symptoms or different symptoms as well. Not only them, but some of them. So like dizziness, sweating, pain up in the jaw or your arm, tightness of the chest. So they sometimes get a bit different symptoms, but it's basically that typical chest pain.
So it's like a band of tightness going around your chest.
Even sometimes, even a fullness in the lower chest or in the, in the upper abdomen.
Maybe this is a good time to bring in Dr. Siobhan Hendrikse, who's an international cardiologist. Doctor, thank you for taking time out to join us on Mansfield today. How is this? How do you intervene in this situation?
It's a great pleasure to be here, Jeremy, and good day to our guests as well. It's not an international cardiologist, it's an interventional cardiologist. I was just thinking, am I on the right show? But just to give you some...
you see my glasses aren't working well.
But your accents are all South African, so I could tell I'm definitely here. Basically, what interventional cardiology is a discipline in the field of cardiology where we actually use catheter-based technology to open up coronary arteries and to fix problems within the heart, just to keep it simple. Now, as we've just heard, angina is a chest pain syndrome that indicates an underlying problem within the coronary arteries usually. Usually there is a blockage underlying, and that is due to a process where the coronary artery has gotten narrowed. And that is usually due to some degenerative process, and that is called atherosclerosis. And I don't want to be too complicated here, so you just tell me when to stop. But we can use our catheters and our balloons and our wires to guide us down the coronary arteries, then place a stent to replenish the blood flow and relieve the ischemia, as you just said.
Doctor, you say that it's usually as a result of some form of degeneration. Is this an age-related thing, or is it degeneration in other forms as well?
Absolutely. Age is a risk factor for coronary artery disease. Premenopausal females, as the doctor said, ladies are special. They have a lowish risk of developing coronary artery disease compared to males. When over the age of 40, we have an increased chance of developing this. And also looking at our current lifestyles, the speed of our lifestyles, the stresses that we are faced with, the tobacco exposure, the advent of hypertension, dyslipidemia, which is high cholesterol, and abnormalities in the bodily fats. Those all are potent risk factors for coronary disease. Including diabetes, which is an incredibly burgeoning epidemic globally, which has a very potent correlation with the onset of coronary artery disease. Now, this process that I mentioned, this degenerative process, and we can go into that in a little more detail depending on the questions out there and the requirements. But basically, this same process can happen in your kidneys, it can happen in your brain. It can also happen in your big blood vessels, like your carotid arteries in your neck, and also in your main artery down your abdomen. So, but our field deals with problems related to blockages within the coronary arteries, within the heart. And I'm showing you a picture of a little model of what a heart looks like. And those small rivulets that you're seeing going through the front part of the heart. I'm trying to get into the camera, trying to ascertain where this camera is. But ultimately, you can see those little rivers of blood going down. Those are coronary arteries. I'm just trying to get a decent picture.
Yeah,
Are we able to
that's
see that
perfect.
there?
Yes, yeah, that's perfect.
That's
You can see
perfect.
them now.
So you can actually, yeah, you can see those little rivulets coming through here. Those are actually coming off from the main blood vessel called the aorta at the back there. And essentially, when we go in and we do our interventions, we try to get our catheters into this little area, and you'll see it's tucked at the bottom over there. It looks pretty complex, but actually, and it is fairly complex. You know, we take it for granted, but any procedure in the heart is very sort of important. So essentially, we get our catheters in there through the big blood vessel, and we can actually angulate it such that it gets through the blood vessels. And in fact, what coronary arteries do, they send blood to this muscle, this very muscular portion of the heart there, which is in fact the business end of the heart, which gets blood to the rest of the body through a pumping action. So when one has a heart attack, when that artery is abruptly blocked by atherosclerosis and a clot that can form in there abruptly, almost like you can compare it to a volcano erupting, like almost like a pimple on your face erupting. The same sort of process can happen in your coronary artery, abruptly blocking that artery and then causing this catastrophic pain that we just heard about, causing ECG changes, and then also causing chemical changes in your bloodstream that we can detect to confirm the presence of a heart attack.
I would like to ask a question, please.
Yeah.
Doctor, if you could tell me, so patients are always worried it gets to coronary artery disease, and some patients, you always think it's open heart surgery, you know, like bypass surgery. So what is the percentage you would say of patients that would be good candidates for stents instead of open heart surgery? And what's, sorry, yeah. And maybe what's the, you know, what is the positives about the stent rather than open heart surgery? I think people would be interested to know.
Sure. Now, the difference between bypass and stenting. Now, bypass requires a cut down the chest, usually via what we call a stenotomy. And these days, if it's a very minimal amount of work that's required, you can even do a minimally invasive procedure, but that's beside the point. A stent is, as I mentioned, going through a minimally invasive puncture, and many more than 90%, I'd say, well, not 90, maybe more than 70 to 80% of cases are now done via the radial artery, which is here. With all the arteries go towards the heart eventually. But the radial artery is sufficiently sizable enough for us to get our catheters up, and also through the femoral artery, where I think the majority of cases are being done in South Africa, if you ask me. Now, in terms of bypass, there are indications for either way. Now, stenting is quite a convenient means of fixing up a coronary artery. We do have international guidelines which can push you in the direction of stenting versus bypass. It all depends on the complexity of the blood vessel that of interest, the multiplicity of lesions, how many blockages are there, what is the level of calcification, have those blockages been blocked for many years, and are they chronic blockages which might be difficult to get stents through. And there are techniques that we can use with interventional cardiology to fix these arteries up. Also, with respect to the background of the patient, how old is the patient? What is the risk factor background? Is the patient diabetic? Are there other problems that might push you in the direction of surgery? Is the patient likely to take medications that we would require for them to be after stenting? Would they be compliant? Otherwise, at the risk of stent thrombosis if they don't take their medications. Bypass is a fairly, you know, there are complications that can occur. Stroke, you can get sepsis, chest infections. And although it's an excellent means of revascularization, we are seeing stents taking the fall in this modern age. especially with all the technological advancements that we have currently. Now, what are the percentages? If I were to look at our center, or just from my experience, I think over 90% of cases would be stented. Less than 10% of cases would undergo coronary artery bypass grafting in this day and age. But it all depends on operator experience, the center experience. It all depends on the background of the patient, the complexity of the disease, and also obviously sticking to international guidelines for which we have certain guidelines going in the direction. So I think that would be the split, probably less than 10% going for bypass these days.
Doctor, final question for you. At what sort of age should one be looking at visiting a cardiologist on a regular basis, having an annual checkup, for example, with a cardiologist? And does that differ between male and female?
Yeah, I would say that if a male gets to the age of 40, it would be useful getting a cardiac check, not necessarily every single year, because it also depends on the risk factor background. If he's completely well, no high blood pressure, cholesterol, diabetes, smoking, and there's probably a low risk. Of course, if someone becomes symptomatic with chest pain, by all means, have yourself checked out, get a screening ECG, a treadmill test, which is an exercise test, might be useful, or any other symptoms of shortness of breath, palpitations, or any other features that would suggest an underlying cardiac problem. But I would suggest that over the age of 50, if you could get yourself to a cardiologist every 1 or 2 years, that's probably a safe point in which to go. Over 60, certainly, an annual check would be advised and useful. Females, as I mentioned, less than the age of 50, the cardiac risk is quite low compared to males. Over the age of 50, the risk starts to level out. So between 55 and 60 for a female, I think that would be a decent time to undergo cardiac assessment, unless driven by some other symptom-based reason, or some other background medical problem that you might have related to a heart.
Oh, so you see, you've still got about 25 years to go.
Absolutely.
Absolutely.
Dr. English, thank you very much for joining us on Mansfield today.
Wish you one, please. Yeah.
Okay, we appreciate your time. Thank you so much.
Thanks so much. Pleasure being here. Thank you so much. Bye-bye.
Bye-bye. Very interesting. I'm glad you brought that up.
Yes.
Yeah, I'm over 50, so I should start going to see a cardiologist.
Absolutely. But now you must remember, it was also, people must know that you can go to your GP with chest pain as well.
Yeah.
It's always a good place to start. There are lots of other causes of chest pain as well, like reflux and hiatus hernia and peptic ulcers, lung infections, asthma, even inflammation of the muscles between the ribs or the joints between the ribs and your breastbone. So there's a lot of other stuff that can go wrong, or it could be a problem, not necessarily your heart.
Yeah.
But that's why if you go to the doctor and we take a good history, we can do some blood tests, we can do the ECG, we can figure quite a lot of stuff out.
Yeah.
So don't leave it.
Yeah, so don't immediately think, oh, I'm having a heart attack.
Yeah, but also don't leave it. So don't say, no, I'm not going to the doctor now, and this is just a bit of heartburn or indigestion. Rather have it checked out. Rather be safe.
Dr. Vicky, thank you very much once again.
Pleasure, Jeremy.
It's been wonderful to have you in the studio again. Tomorrow we'll be talking travel, and we've got a huge amount of good news coming in the travel show tomorrow. Until then, keep safe. Bye-bye.